you'll see the little recording light show up there. I'll get us started and then we'll dive in. So welcome. We are here today with Fabrizio Didonna. Thank you so much for joining us on Noble Mind.
You're welcome. My pleasure.
Maybe we could start off with just having you tell our listeners a little bit about yourself and your work and your interests.
Well, I'm a clinical psychologist and also a father. And these are my main jobs or missions in life. I'm also a director of a specialized unit for OCD and a unit for mood and anxiety disorders in a private hospital in Vicenza, Italy. Vicenza is a little town close to Verona and Venice.
Mm.
But I am also the director of the Mbct for OCD Center in Vicenza as well. I'm also a part-time professor at the University of Barcelona in Spain and visiting professor at the Shanghai Jiao Tong University in China, where I collaborate in several research projects about the effectiveness of the Mbct for OCD program. My therapeutic background is in CBT, in cognitive behavioral therapy, and my interest in mindfulness started at the end of the 90s when I began to meditate meditate myself, and gradually started to introduce meditation in my clinical work with patients affected by severe disorders, admitted in an inpatient setting in the hospital where I work. Then I attended the workshops and trainings with John Kabat-Zinn in MBSR and with Zindel Siegel, Mark Williams, and John Teasdale in Mbct for depression, and many others, also others training with others leading mindfulness-based teachers and authors. And I started to share the possibility to adapt these mindfulness-based programs for obsessive-compulsive disorders with them. And what I found in my clinical experience is that mindfulness and self-compassion, when integrated with CBT, are probably the best approaches for this kind of problem, because they directly address the main cognitive biases and the mechanisms that activate and maintain OCD. So after about 10 years of trial and error, I was able to standardize the final protocol, which is now explained, illustrated in the Mbct for OCD manual, published last year by Guilford Press.
Fabulous, thank you. And I'm wondering, for our listeners who may not be as familiar with mindfulness-based cognitive therapy or even obsessive-compulsive disorder, if you could, maybe we'll sort of step back and just kind of help people understand these ideas of obsessions and compulsions generally. You know, in the US at least, the words are really thrown around in very non-clinical ways. People might say, I am obsessive about having a clean home, and all they mean is they prefer things to be clean. So maybe you could just help explain what these words sort of mean, what they don't mean, and maybe we can go from there.
Yes, I think this is a really interesting question, because first we have to consider that in psychopathology, there is always a continuum between normality and pathology. It means that any of us can experience various attitudes, behaviors, or thoughts or mental states that may be considered pathological, when they become too frequent or intense and enduring. So as is the case with the most psychological disorders, OCD originates in normal and potentially adaptive human attitudes, habits, and also behaviors, which turn into a psychiatric disorder when they become too intense and or frequent, causing distress and compromise or interfering with the daily functioning. In fact, we know that most people experience intrusive thoughts and engage in rituals, and that these habits start developing in normally in infancy and childhood, because they provide a sense of organization, balance, and safety and control in daily life. And for example, we carry out a certain set of behaviors in the same sequence every time we do them. We may keep certain objects in the same place, or we eat the same foods in the same order. For example, for breakfast every day. In my case, for example, I eat the same biscuits for probably 40 years. And it's very difficult for me to change.
Or, I'm thinking about the order of showering, shampoo first and then, wash the face, or whatever your order is, that you do things like that.
Yeah, you also have your ritual, your own ritual. Or we may clean our homes in the same way, using the same products, yeah. Also many people, for example, smoke a cigarette after meals or sexual activity. And we have intrusive thoughts that whose content is not different from the intrusive thoughts that people with OCD have. This is also interesting. And our culture, social lives, and religious practices are characterized by rituals, by ritualistic behaviors that regulate, coordinate, and organize our relationship with the outside world, and as well as our inner worlds, But even though rituals can give us a sense of order and stability, we have to continually adapt them to what is going on in our lives to remain functional. In people suffering from OCD, the triggering of certain psychopathological mechanisms leads to an often serious distortion in the duration, frequency, and intensity of behaviors that were initially normal. In turn, this distortion leads to the development of their complex and disabling disorder. So, with respect to the clinical obsessions, this is the main question. Clinical obsessions are often considered to be, or normally are, thoughts that express a doubt or an hypothesis or an inference that the person experiences as being intrusive, negative, and inappropriate. They normally cause anxiety, distress, or other negative feelings that lead the person to try to get rid or neutralize them by performing a compulsion or a ritual. They are normally connected to so-called inflated sense of responsibility, which is a strong, scary idea that the OCD sufferer could be responsible for a terrible consequence to themselves or others if they do not act, if they do not do something to prevent that consequence. Some examples of obsession can be maybe I didn't lock the door this morning, or maybe I forgot to turn the lights off, or I might be dirty, I might have caused an accident with my car, or another typical obsession is I might kill a family member by using knives, poisons, or a car, or fear of being contaminated or contaminating others by infections or disgusting substances or objects.
Mm-hmm.
This is a typical clinical obsession. And on the other side, the clinical compulsive behaviors normally are repetitive behaviors of rituals associated with the disturbing emotions, in particular anxiety or disgust, that the individual feels compelled to perform over and over again. And the aim of these behaviors is to prevent or reduce the distress caused by one's obsessions, or to prevent, neutralize, or counteract obsessions themselves, or make them go away. In other words, the compulsions help reduce an individual's perception that he or she is or has been responsible for hypothetically harming him or herself or others, and make the person feel more comfortable, or that he or she has done the right thing. For example, people with contamination obsessions can decrease the mental distress they experience by washing their hands over and over again until their skin very often becomes cracked and dry. Or people with obsessive fears of intruders may check and recheck doors, locks repeatedly. Or others may check that the gas light or a tap is off. Or driving around to make sure that they haven't run over a pedestrian.
Mm-hmm.
People with obsessions about order can try over and over again to arrange things seeking symmetry or perfection. Or other may need to count in certain patterns, or have to silently repeat special words or phrases. Or people with blasphemous obsessions can engage in excessive praying, or in behaviors triggered by religious beliefs or fear. So these are the most typical obsessions and compulsions.
Mm-hmm. As you list those, I'm just really struck by how much suffering it must cause to have those. Some of those thoughts you described are just so troubling, to imagine that you might have hit a pedestrian and not know it, and then to have to drive in circles to check and recheck whether that's happened or not. It just sounds like a tremendous amount of pain. So yeah, and just so to clarify, the obsessions are the sort of thoughts that you're experiencing that have become really intrusive and emotionally sort of distressing and problematic, and then the compulsions are those behaviors that you're sort of compelled to do to try to manage the distress that those thoughts are causing. Is that?
Yeah, this is a really terrible condition because probably many people ask when an obsession can be considered pathological, no, or problematic, because one criterion is that these intrusive thoughts and repetitive behaviors significantly limit the person's life in one or more areas and interfere considerably with daily life at work or school or with social activities or family relationships and or normal routines and also generally obsessions and compulsions take up excessive amounts of individuals' time, normally an hour or more each day. I had some patient that had about 16 or also 18 hours a day of rituals and obsessions.
Wow.
This is a really terrible condition.
Yeah.
And another criterion is that both obsessions and compulsions cause distress and suffering in terms of disturbing feelings and emotions. But you also have to consider this continuum between normality and pathology in OCD.
Absolutely.
For example, I remember hearing that fighter pilots are known for having a lot of rituals and superstitions, for instance.
Yeah.
So even people that society sees as super brave, when faced with
this is very, very normal because in particular in Italy, in south of Italy, the magical thinking and superstitious thinking is quite normal. So it's very interesting to see what is the limit, the border between normality and pathology.
Yeah, the religiosity piece is interesting. It seems like, as you're describing some of these, there's some domain of OCD seems to manifest around religious topics or themes, or as you're saying, the sort of rituals, we have places in our world where ritual is really condoned and desirable and helpful in some way.
Yes.
Yeah.
And what may be potential root causes that lead people to be more vulnerable to developing OCD?
Yeah. As with the most psychiatric disorders, research has not yet been able to identify definitive and clear causes of OCD that are common to all individuals with this disease. Particularly because, OCD is a really heterogeneous disorder. It is very difficult to find all the possible causes of these different types of OCD. But there are a range of factors and conditions that have been identified as contributing to the development and maintenance of OCD. And it is likely that several factors are involved for each individual affected by the disorder. We know, for example, that there is a specific interaction between genetic and biological or neurobiological predispositions. Also environmental factors, for example, life experiences, parental modeling, education, or an hereditary component. So there is quite often a father or mother with OCD or an obsessive personality. And also we have to consider attachment history. So the particular relationship that the infant or child developed with his or her primary caregiver, normally the parents, and all of this can drive an individual towards the development of OCD.
See. And are there similarities and differences between a more characterological presentation of OCD versus OCD as an Axis 1 clinical disorder?
Yeah. Characterological OCD is normally called in psychiatric terms Obsessive-compulsive personality disorder or OCPD. And it is characterized by, normally by extreme perfectionism, order, neatness, and rigid adherence to rules. We can say that they have an obsessive lifestyle and the way of being. So they do not have normally obsessions and compulsions like in OCD. But people with OCPD often feel a severe need for control and to impose their own standards on their outside environment. And for this reason, they often feel indignant and angry with other people. Because, of course, most people are not available to follow their rules. They also find it hard to express their feelings and may have difficulty forming and maintaining close relationships with others. And they are often hardworking, but their obsession with the perfection can make them inefficient. Normally, the condition that they live. People with OCPD have no idea that there is anything wrong with the way they think or behave. They believe that their way of thinking or doing things is the only correct way, and that everyone else is wrong. So critical elements in the differentiating OCPD versus OCD are the obsessions and compulsions normally. A person with OCPD will have some rigid behaviors, but they will not engage in the overwhelming need for repetition linked to OCD, to OCD compulsions. Another basis for determining OCD versus OCPD is the level of insight and self-awareness. Most often, a person is fully aware of OCD and the problems it causes. But OCPD is different. A person with OCPD usually believes their thoughts and behaviors are normal. And other people are the ones who need to change. In OCD, problematic thoughts and behaviors normally create distress and suffering and are seen as irrational and dysfunctional. And this is not the case of OCPD. Furthermore, OCD usually affects all or most aspects of life, making work, school, or healthy relationships very difficult. In OCPD, normally only some life areas are compromised. Anyway, it is quite possible to have both an OCPD and an obsessive-compulsive disorder. In my clinical experience, it's a quite common condition. If you want to see a clear example of an OCD plus an OCPD, you can watch the wonderful film with Jack Nicholson, as Get as It Gets,
Oh, right. As good as it gets. Yeah. Mm-hmm.
Yeah.
Oh,
Right.
And you can see an OCPD with OCD.
Mm-hmm. Interesting. Mm-hmm.
now, despite the heterogeneity of obsessive compulsive phenomenology, there are common elements. You're right. I wonder if you can share those.
Yeah. The common element is the rigid beliefs normally they have that in OCD drive people to act in a ritualistic way, act the compulsions, and in OCPD leads the person to have a very rigid behaviors, very rigid attitude and a relationship with other people.
Mm-hmm.
But this is one important component in common. But I very often see these two problems together in several people, because normally it's very difficult to find an OCD. In my clinical experience, I found difficult to see an OCD person, people with OCD that have an onset without years of pre-morbid attitudes and behaviors.
Mm-hmm.
So they normally start in infancy, childhood, and teenage with subliminal obsessive behaviors. And then the problem became more intensive and problematic at a certain moment. That's the moment when they have a diagnosis. But normally the problem do not start in that moment.
I've also heard you say that OCD attitudes and behaviors are common in several disorders that are not all OCD, such as eating disorders.
Yeah, there are several. That's probably the reason, because in the last DSM, the DSM-5, OCD is now the main disorder of a spectrum. Because it is quite clear that many psychological problems have components, very similar components, several components very similar to OCD, and in particular repetitive behaviors, or rigid schemas, or intrusive thoughts, worrying, and so on. So we can find obsessive behaviors in eating disorders. We can see intrusive thoughts in generalized anxiety disorder, or hypochondria, health anxiety. It is quite strange that hypochondria or health anxiety is not included in the OCD spectrum in the DSM-5, because in my experience, I found that hypochondria is definitely an OCD problem.
Wow.
What is different is just the final contents of their obsession. But I also have several patients in my Nbct for OCD group with hypochondria, and I found that it is very helpful for them, because they have, I think they have the common mechanisms and biases that leads to that form of OCD.
This seems like a good time to bring in the question at the end of the list, and then we'll circle back and get into Mbct treatment more deeply. Do you see any relationship between compulsive behavior and addictive behavior? I know some people talk about compulsive shopping or compulsive gambling. So sometimes it seems like those words are used loosely, or people talk about behavioral addictions or process addictions like sex or shopping. Do you see connections there, or do you see that as part, or how would you differentiate that, or would you?
I think this is also an interesting question because actually, I don't think these terms are actually appropriate.
Mm-hmm.
So the term compulsion linked to sexual behaviors or shopping and so on. Since when we talk about problematic shopping, sex or gambling, we are referring more to impulsive, not compulsive behavior.
Mm-hmm.
Just because these actions and attitudes might be experienced as uncontrollable,
Mm-hmm.
they are also pleasant or exciting,
Mm-hmm.
and not performed continuously in a repetitive way. Differing greatly from obsessive rituals, which normally create distress and the negative feelings.
Mm-hmm.
In fact, I normally use uncontrolled as a way to describe shopping, sex, or gambling, not compulsive.
Mm-hmm. So they tend to, I'm thinking about, as you're saying, they tend to trigger the reward chemicals in the brain and lead you to want to do them more and more to get more of those reward chemicals, which is a very different experience, as you're saying, than these compulsions, which are very distressing and cause a lot of struggle.
So compulsions always, I'm sorry.
No, go ahead.
To clarify, Anissa. So compulsions are experienced by the person as unpleasant, even though they feel compelled to perform them. Is that right?
Yeah.
Okay, gotcha.
Yeah, compulsion normally are experienced with suffering, with anxiety, or with disgust, with a lot of distress.
Mm-hmm.
But normally, all the form of compulsion that you mentioned before, sexual or gambling or shopping,
Mm-hmm.
do not create suffering, but create pleasure. They are normally experienced as exciting experiences.
Mm-hmm.
And that's why they are not able to stop. They are not able to finish this kind of behavior.
Really helpful distinction. Thank you. So let's talk a little bit about mindfulness-based cognitive therapy for OCD. This is an innovative treatment that you've developed, and we'd just love to hear a little bit more about how you think of mindfulness and how, the ways in which it is helpful for OCD, and a little bit about the treatment.
Yeah. Mbct for OCD developed from the need to integrate what is currently most effective in treating this challenging condition with the principles and practices of Buddhist psychology, focusing not so much on the symptoms of the problem, but on the processes that activate and maintain this clinical problem, which result in particular from the relationship people have with their private experience. And what I noted throughout my long clinical experience of using mindfulness for OCD with, I can say, hundreds of patients, was that patients responded well to these kinds of meditation practices and approaches, and very often found consistent relief from their problems by changing their perspective and the relationship they had with their internal experience. And by internal experience, I mean thoughts, emotions, and sensations. And this change in perspective is one of the main therapeutic factors in these approaches. There is a wonderful quote from the Anguttara Nikaya, which is an ancient Buddhist text, that explains, in my opinion, very clearly the sense of this change in perspective we want to develop through mindfulness to overcome OCD. And it says, not through actions, not through words, do we become free from mental contaminations, but by seeing and acknowledging them over and over. Mm-hmm. You know, I think that's really interesting because this quote summarizes the core the core meanings and principles of a mindfulness-based approach to OCD in several ways. It's a sort of Buddhist therapy of OCD, for OCD, mm-hmm. because it highlights the importance of changing the relationship people have with their own internal experience, not the contents of the problem, mm-hmm. Obsessions and compulsions. That's why I found helpful. I found that Nbct for OCD can be helpful also for other psychological conditions, psychopathological conditions.
Do you have a sense what those may be? I'm sorry.
Sorry?
Do you have a sense what those other conditions would be? That it would.
Yeah, for example, eating disorders, in my opinion, or other form of anxiety disorders, or of course for hypochondria or health anxiety, mm-hmm. Because it intervenes in some common cognitive factors that are common in several psychological disorders, not to the specific final result of their those mechanisms, you know. So this is one important key feature of Mbct for OCD. But there are also some other core feature of this therapeutic model. One is understanding, which means helping participants to gradually develop a deeper and clearer understanding of how OCD works. For example, causal, activation, and maintenance factors and mechanisms, and how mindfulness training can effectively intervene in replacing those factors and mechanisms with the new healthy and adaptive behaviors. In fact, I often say to participants in my group this sentence, understanding is the first step to healing. Mm-hmm. In fact, the first 2 or 3 sessions of the program are dedicated in particular to this factor, to this aim, so understanding. Another important key factor in this model is normalizing. So participants come to see that their reactions are not as unusual, strange, or crazy as they had previously thought. when the behaviors, ideas, and the convictions that are considered normal for most people become extremely frequent and intense, one of the possible results is the development of OCD. So mindfulness practice can serve as a powerful tool in the process of normalization, because it allows participants to see reality for what it is, and to understand how the mind distorts it in several ways. And a further core feature is in this model is trust. So it is a really important to help participants to develop a real and mature feeling of self-trust, since mistrust can be considered a basic component in OCD, and the one that activates and maintains most obsessive symptoms. I also define OCD as a trust disorder in my manual. And of course, another important key feature of this model is an intensive training in mindfulness and self-compassion. Since they can help participants develop new mental habits, attitudes, and states, such as awareness, decentering, acceptance, wisdom, and compassion, that can effectively change or neutralize their obsessive mechanisms and biases. There are also other important factors, but
that's a fact. There's so much to go on right there. One thing, as you were talking, is really your underlining of obsessive compulsive disorder as a trust disorder. I'd love to have you unpack that part a little bit more, because it's not entirely apparent.
Yeah, this is one of the main aim in my work, and also in the manual. You will see, because it's not specific only for OCD, but in OCD it's very clear that mistrust is the main factor that leads these people to obsess themselves and to perform, to act in a compulsive way, because actually they do not trust their memory, for example. They do not trust their perceptions. They do not trust their intentions. And everybody, if you also do not trust your intentions, memory, and perceptions, probably at a certain moment you will start to have several obsession, intrusive thoughts, and try to defend from them through compulsions and rituals. So
yeah. I can see that clearly if I imagine myself not being able to trust those sort of foundational aspects of my experience or my thinking, that I'd probably pretty quickly develop some set of rituals or behaviors to try to manage that.
Yeah.
Yeah.
Also, I'm struck by your approach, from having read your book, that like Paul Gilbert talks about how courage or compassion is the courage to descend into human suffering. And it seems to me the standard approaches to treating OCD are more focusing on symptoms, whereas your approach descends into or enters into the experience of the person. Like, what is it that they're struggling with exactly?
About the senses.
Right, about the senses, about why things are happening, instead of just changing the frequency of a behavior without looking at the root and branch of the dynamic.
Yeah, as I told you before, in the Mbct, the aim is not to change the intensity or the frequency of the problematic symptoms, so obsession and compulsions, but the aim is to help these people to change their relationship with the internal and external experience.
Mm-hmm.
That's why Mbct can be transversal to several problems, psychopathological problems.
Mm-hmm.
And mindfulness and compassion are trainings that can be really powerful in order to change our bad habits, our pathological habits, in particular mental habits that drive to this kind of problems. And that's why I introduce in this model also compassion as an important component. This is quite different from Mbct for depression, in which compassion is an indirect component, but not specifically included in the practices of the program.
Mm-hmm.
So it's about transforming the way the person is relating to reality, to their emotions, thoughts.
Absolutely.
Yeah.
OCD people have a big problem in take care of their suffering, and actually they create their suffering over and over again, and they are not able to understand that the biggest suffering that they create is not the one they fear to experience in the future, but the one that they create moment by moment with their problem. This is also another important reflection that we have during the group, and explanation of why we use self-compassion at a certain moment in the program.
Mm-hmm.
It seems to include sort of radical validation of the person's experience, trying to get them to connect to what's their inherent wisdom or develop their inherent wisdom, but also acceptance of both reality and emotional experiences, and the self-acceptance, as well as self-forgiveness. So it's really sort of multidimensional.
Yes, I also introduce a practice which is called self-forgiveness, which has many connections, of course, with self-compassion, where self-forgiveness is a sort of self-acceptance practice, because people affected by OCD need to develop an acceptance about their condition of fallible and imperfect human beings.
Mm.
And this is very difficult for them to accept.
This sounds difficult for everybody on some level, but this,
Yeah.
Right, but amplified in this condition, certainly.
Yeah, but for OCD, it became a disorder.
Yes, right, yeah.
So it almost sounds like Plato's symposium, sort of like or academy, in the sense that the issues being addressed are fundamental philosophical issues, almost about life and how to have meaning, how to relate to their various things, as opposed to stop doing that.
Yeah.
And just to underline for listeners, so Mbct for OCD combines mindfulness-based stress reduction, mindfulness-based cognitive therapy, compassion-focused therapy, and acceptance and commitment therapy components. Yeah, if I'm correct. Yeah.
Yeah, there is. I try to integrate in a rational way all of these mindfulness-based approaches. Of course, the main approach is Mbct, but Mbct derived from MBSR.
Mm-hmm.
We have about 80% of MBSR in Mbct.
Mm-hmm.
But also compassion-focused therapy is an important approach that I included in several parts of this program. In particular, in the cognitive evolutionary explanation of OCD. It is an important part in the first chapters of the manual. And cognitive evolutionary explanation of OCD gives an important rationale of this model, Mbct for OCD model. And also, there is also part of ACT, or acceptance and commitment therapy, in particular in the use that we do of metaphors in several practices, meditation practice. You know, in ACT, metaphors is an important component, because I found metaphors are very effective to help people to develop metacognitive skills, and to develop some mindfulness skills, such as decentering, disidentification, and also OCD. People with OCD found very helpful some metaphors that we use in the program in order to develop the skills.
I'd love to talk a little bit about exposure as it sort of shows up in Mbct and your thoughts on that, because generally the quote gold standard treatment that people get recommended to when they get diagnosed with OCD is exposure and response prevention, which is a pretty intense protocol of, you know, having to expose oneself to the things that one most fears, and enduring the fear and anxiety that arises, and learning that the feared outcome doesn't happen. And I know there's some exposure in your protocol, but I'd just love to hear your thoughts about what mindful exposure brings to the table, and how it maybe changes a little bit from the sort of traditional treatment that's on offer out there.
Yeah, well, Mbct for OCD is designed as a comprehensive and integrative approach to OCD, not as an alternative to CBT. Because it actually includes the most important components of CBT. In fact, I introduced in the program an important practice, an important exercise, which is the mindful exposure, which is an integration between mindfulness and ERP that can better help people with OCD to accept exposure, which, as you know, is a very anxiety-evoking procedure technique, and this is the cause of a lot of dropout from the therapy. You know,
I was looking before this interview just for some numbers, and I think it's something like 30% of people either don't start or drop out.
Yeah.
So
about 25 to 30% of people drop out from CBT because of the too anxiety-provoking techniques. In mindful exposure, the approach is really different, because person enter into the situation, the obsessive situations, in a mindful state. So they practice a mindfulness exercise before to expose themselves, and then when they are in the situation, they use all the mindfulness skills they learn in the program, because we introduce mindful exposure in the 8th session of the program, so they learn a lot of skills. So when they expose to the obsessive situation, they enter in the situation with an attitude of acceptance. They are able to decenter themselves from the thoughts that come up in that moment, intrusive thoughts that come up. They are able to give value and validate what their senses say to them in that situation, because we say that the senses are the best antidote to the doubts, to accept the doubts. So they they experience a really different approach, a different experience compared with the classical behavioral ERP. And normally what they noticed is that anxiety do not increase so much during this kind of exposure. They're able to stay in touch with the situation without the ritualize. And normally they are able to neutralize this kind of problem, this kind of situations in a few sessions, in a few practices, in a few sessions of mindful exposure. And this is very interesting. But another thing, important thing is to know is that research data show us that standard CBT is a very effective therapeutic approach. You know, is a gold standard.
Yeah.
But it also has been shown to have some limits. In fact, we know that about 50% of people suffering from OCD treated with standard CBT do not respond well to the treatment or relapse, as we told before, or relapse after a certain period. We have now some preliminary data. In particular, we have an open trial and 2 randomized controlled trials that show Nbct for OCD is very effective at the end of the treatment, and that the outcome is maintained at follow-up. We need, of course, further research to demonstrate if Nbct is more effective than CBT, but the preliminary data are really promising. Furthermore, we have to consider that Nbct for OCD, when it is provided in group, can be more cost-effective than individual standard CBT. And it can also be more helpful for people with a comorbidity. So when there is a simultaneous presence or 2 or more disorders in the patient. Because Mbct for OCD, as I told you before, is not focused on the specific symptoms, but on the general attitude and the relationship a patient has with his or her internal and external experience. So I think these are some of the most important issues to consider in using Mbct for OCD. Okay.
I mean, to give our listeners a sense of what's involved in mindful exposure, so there's meditative sections at the beginning and at the end. There's a clarification of motivation, keeping the therapeutic goal in mind, and then having the client do their best to stay in contact with the disturbing situation. And also a great deal of openness about, like, what are the thoughts, sensations, emotions that are arising? Trust what you're feeling. Trust your senses. Remember, thoughts are not facts. You know, there's acceptance thrown in there, using quotations almost like mantras to keep the person on track. So it's quite different, I think, from a classical ERP, unless I radically misunderstand ERP.
Yeah, it's very different because the aim is not to wait that the anxiety increase at the maximum level, which is, of course,
that's the active ingredient in the traditional ERP.
Yeah, an important reason to drop out.
Right.
But the main aim is to relate to the situation in a more realistic way as possible, you know. And So to see and perceive the things as they are, not as their thoughts say to them. This is a totally different approach.
Yes, yeah. So I'm noticing the time here. We've got just a couple moments left. Is there anything that we haven't asked you or you'd like to circle back and make sure to say before we wrap up, or should we move towards closing?
Do you have any other questions?
Oh, my question to you is, do you have anything you'd like us to ask?
Okay. No, I think maybe we covered many important issues, and I don't know if you want to have some information about more information about Nbct.
Yeah, that'll be our final closing question. So let's go ahead and do that. Do you want to ask that one, Alex?
So
where can people find you and engage? That's
okay, sure.
Yeah.
Well, yeah, sure. Does this sound like is this a good time to wrap up? We could discuss more things. Is there what do you think, Professor?
Yeah, it's okay.
It's good. Okay. All right.
Yeah, okay.
So where can people find you, engage with you and your work? And how can people receive Mbct for OCD? And how can clinicians get trained to offer it?
Yeah, I think that the best way to get more information about Mbct for OCD, about my work and contact info, is to visit our official website. That is www.mbctforocd.com. It has important information regarding the model, regarding the program, workshops and trainings for professionals, centers that provide this therapeutic program, and also more info about the manual and myself. Actually, Mbct for OCD is in its infancy. The manual has been published just 1 year ago. But we already have some centers, for example, in China, in Israel, in Spain, in Italy, and I also hope we can have a center in the United States. And this depends mostly on the training that we can give in the next future. But you can also see in the website also the workshops and training program that we have for this model.
I mean, this is going to be out of order, but I was also struck by how much embodiment embodiment work is encouraged. The mindful movement.
Yeah.
So that's also, maybe that's not something that would jump to mind when people think of OCD treatment.
About the exercising movements, is this the question?
That's right. Yeah. So that the person can really start to experience life from the inside of their body.
Yeah.
Yeah.
Yes. Balance is the most important component of well-being. And in this program, we help participants to create the best integration and the best harmony between mind and body. So from the fourth session of the program, in each session, we include an exercise in movement, a meditation in movement, and a dynamic meditation, for example. And these are also important because it helps people to create the best integration between mind and body. But it is also important because as you can understand, very often people with OCD is difficult to stay still for a long time. And the possibility to meditate in movement is a really important option that they have in this program. And they find very helpful to create this particular attitude and skill through the movement, through the body in movement.
Wonderful. Thank you so much, Professor Didonna, for your time and for sharing your knowledge and thoughts with us.
My pleasure.
Thank you so much. Take care.
Thanks to you.